But I'm Matthew Tolliver. I'm one of our outgoing co-chairs for the year. I work as the Director of Behavioral Health for the Pediatrics Department at East Tennessee State University in Tennessee. And been working with JUICE this year to kind of coordinate this group. And we've worked all year and focused on the pediatric mental health crisis and have had some really good conversations. JUICE and I were reflecting back over the year as we met last week, and I just feel so thankful to be a part of this SIG and connect with so many cool people around the country. And we're talking about how, we've got representation from like boots on the ground BHC folks on the call usually, and then we have other like administrative people or director of behavioral health folks. We've got researchers, we've got people doing kind of policy stuff. So all sorts of things. And I think that's one of the things that kind of gives us strength is just we're able to pick a particular topic and then really hear about it from a lot of different perspectives and from a lot of different settings, really, which is pretty cool. So we always want this to be conversational and practically helpful to you all. So we usually have a kind of if you haven't been much before, kind of this broken down into a couple different segments. So we're so excited to have Verna Little here with us to talk about suicide kind of crisis management prevention in the primary care setting. And then we have a facilitated discussion too around each topic. So that's time where it's not just like a webinar for the whole hour, right? Like we want to hear from you, hear what your questions are, your thoughts are, and so we can kind of get a lively discussion going. And if you're ever interested in presenting on a topic for us, hosting a facilitated discussion, telling us a little bit about who you are and how your model works, we would love to have you participate and do that. And just let us know, and we'll bake that into future meetings. One of the things that we wanted to announce at the beginning here was just who our leadership team is going to be moving forward. And I was saying I'm kind of rotating off the co-chair position, and so excited that Rachel Petz is going to be rotating on. She's our research lead on the leadership team that's going to be taking over as the co-chair with JUICE. And then Dr. Amelia McClelland, who's on from Washington, is going to be moving into our membership and engagement role. And then our student representative, Jonathan Larson, is going to be moving into what Rachel was doing, kind of coordinating some of those research corners and being our research lead. And then the other folks are going to kind of stay the same. Michelle Swinger Gagne is going to be our secretary. She's waving. We're so excited to keep you on. And who else am I missing? Shoes.
Sorry, I'm writing my own who I am in the chat. Like I didn't feel right that people were doing that, and I was not.
Yes.
Bad multitasker, I guess.
I'll let you introduce yourself, Juice, and then maybe you can set up our topic for today, if that's okay.
Yeah. Yeah. Well, a lot of people have also chimed in on the chat, and we also have Daniela, who is the newest team member. So welcome, Daniela, and the rest of you as well, of course. So today we had a great conversation in the last SIG about screening for depression and suicide following the USPF TS recommendations about screening. And then I think it's not avoidable to talk about screenings without talking about outcomes using measures. So it evolved naturally in the conversation to talk about what people were using for that. So we decided to continue the conversation and talk about outcomes as well, which we would be doing today and next month. And Virna was very helpful, volunteering for today to present on her organization work for screening and tracking suicide. So I will let her share. She has a lot to say. She sent us wonderful materials that we will send to all of you. But I think for the sake of time, we want her to start as possible. So welcome, Virna, and thank you.
Well, thank you. It's a real pleasure to be here. And so I'm Verna, and I'm actually coming with wearing a couple of different hats. So certainly, most importantly, I'm a co-founder for Concert Health, and we've got some team members actually. I see Julie and Liz on the line as well today from Concert. Also have been very privileged to be a part of the National Zero Suicide faculty. For about 6 or 7 years now, doing some of that zero suicide work, and most recently working with the AMA and some other groups around developing materials for integrated care settings and primary care providers around pediatric care and suicide safer care in the peds populations. We did some work with NIMH, also working around adult pathways. And so really wanted to sort of bring in for discussion some of the things that are sort of going on nationally, some of the things that we've set up at Concert to really start to respond and think about how to identify and care for people at risk, and sort of what some things to think about are some best practices. So I shared a bunch of information and articles that you can, get, and maybe some would be helpful and useful. And really wanted to sort of have a discussion, answer questions, have some discussions, because I think there's some things happening in the field. Certainly that rise of suicides in the 10 to 14 has been interesting for a lot of people nationally, because sort of the 12 and up, we kind of have a lot more workflows and things. But when you start to go to the 11 and down, that's when people start to get into a little bit of a conundrum about sort of what to do, and thinking about different populations. So our 5 to 9 versus our 10 and 11 versus our 12 to 16, and starting to think about what that looks like how do we do something different, and thinking about each of those as different populations. So I know there's a couple of things that we've really found helpful that I wanted to really think about, sharing. One is that we've really learned that it's helpful to think about a pathway. Like if you go to the Zero Suicide website, or you go to places, to think about what does a pathway look like for how do we care for people at risk for suicide in the organization, which is very different than a workflow, right? A workflow is who does what. A pathway is much less about who does what, and really focuses on kind of what needs to happen. And so it's really helpful to think about. I know when we started to do the work at Concert, and then, when they started to do the zero suicide work and where it sort of originated at Henry Ford, if we were going to take excellent care of, a pediatric patient and adolescent at risk for suicide, what would we do and what would happen? And so a lot of the work in the pathways sort of came out of asking those kinds of questions. And we've really thought about what are some of the best practices. And so always think that it's really helpful. I'm just going to share some things, that actually might be helpful to look at. So when we think about what a pathway might look like, this would be a pathway as opposed to a workflow. So in other words, it's much less about what happens and when, versus this is how we might identify people, and this is what happened at what cadence. And so this is on the Zero Suicide website. There's also, I sent it out to be shared, just so you could really get an idea of what it might look like instead of a workflow, and to really think it through. How do we identify someone? What tools do we use? How often does that happen? Certainly for the pediatric population, I think you see the ASQ more than the CSSRS, which is reflected here, particularly for the 11 and down population. I think you're going to see that more, but that's just a little bit about what that might look like. The other document that I shared that I think might be helpful for folks, to put a lot of things on the, so let me just pull it up and then I can share it, is to really support, particularly if you're doing organizational training, to particularly support why are we doing this. So one of the documents that we've really worked on and continue to do and have continued to sort of use is a research. So how does research support what we're doing? Why are we using it to inform our workflows? And what does that really look like? And so I'll share this briefly so that you can see what it looks like. We're really glad to share anything like this. So why are we doing safety plans? What research supports it? Means restriction, means restriction. Why are we doing things in terms of follow-up? So to support your workflow, what research actually supports some of the decisions that you've made? And one of the things we found is that in training, it's really helpful to show this and continually update it so that you, one, keep track of some of the latest and greatest that's happening around research. One of the things that we're looking at recently is the amount of time that it takes for some of the research to get played out. And even though you might share research, like it's really important to ask about guns in the home for all of your pediatric patients, that it actually doesn't happen in practice, even though we tell people it doesn't often change practice. And so it's important to really think about, here's the research for some of the operational and organizational decisions that we're making. So wanted to share a little bit about some of the thoughts that we've had at Concert and what some of the other organizations nationally are doing, is really thinking about their populations of patients who are at risk for suicide as a population. So how do we know how many people we have at risk? Do we know that? Are we using the ICD-10 code to identify them? That's a huge piece in terms of really making sure you actually know how many people you have. And then one of the things that's really been happening nationally is actually stratifying and thinking about who are the people in that population that we need to know about and maybe do something differently. So when we started to think about it, we were thinking about, there's a group of people that have been at risk for suicide in the past, but aren't now, but yet we know they're more at risk for suicide the rest of their lives, right? And so we do want to know on some level that they had a history of suicide risk, and we want to use that to inform care. Like, is something similar happening in their life? We want to make sure that we know it. And so we put people in a bucket, like a historical bucket. And then we have people that are on the other end that are very high risk, that we are acutely concerned about, people that have shown intent, right? Because one of the things we know that really changes risk is intent. So they've answered yes to that question 5 on the ASQ. They've answered yes to the intent questions on the Columbia scale. So these are people that we think are very high risk. And so we want to do something different for those folks than we do for the folks that are in the historical bucket. And then we have people that are in the middle that we're watching and we're treating, but maybe we don't think are as acute and not yet historical. And so what that means is, maybe for our high risk people, what do we do different for them? Maybe we contact them at different intervals. Maybe we have different people follow them. Maybe we get or give different supervision, right? Versus historical, where maybe we ask if they're safe when we see them, or maybe we do that a couple of times a year, right? They get a Columbia scale or an ASQ. And so as you go forward in this work, really thinking about, how are we thinking about our population, and are we doing something different for different groups of people? And so that's how we sort of landed at what that looks like and how we're really thinking about moving some of the suicide care forward, and then thinking about what that looks like. And so I'll just share so that I can walk through a little bit. And these are, you know, just some samples. This is a little bit of a combination of Concert and some others. So I will share, but thinking about what you want to do on your pathway. So how are you identifying people? Are you doing something different by ages? So we really, and what a lot of places are doing, actually talked to someone recently at a large outpatient mental health. They're in several states, and they are, they've changed this a little bit. So they do 16 to 25. They do 10 to 15, and then do 6 to 9. So really thinking about those age brackets and bucketing people out. We made a decision to use the ASQ. I personally think it's a little easier to use for the children and adolescents, the young adolescents, like up to 15. I think the questions are easier. It's used in most pediatric emergency rooms for just that reason. It also has the really nice toolkit on the NIMH website with information you can give to caregivers and to nurses and all of that. So we actually, I also think it's a little bit more supported by the research for the younger ones. The Columbia scale, ages 16 and up, a lot of organizations are doing that, you know, 16 and up is sort of what you're really seeing, even though both tools are for all populations. I think, you know, people are finding some differences in the field. So really thinking about those populations and what tools that you're doing, and then what do we do for the folks that are at high risk. So for example, if we have someone that is acutely at risk, they're in our high risk bucket, maybe we don't want to go more than 7 days without contact with them. Whereas someone who's at risk, maybe it's 14 days. We want to make sure they're getting the ASQ and the Columbia scale at every single contact, right? One or the other, whichever, at every single contact. We want to make sure that they've got a really good safety plan and that we're reviewing it, whether it's, you know, every time, as an example. Did you use your safety plan? Has anything changed, right? Really thinking about what that looks like. And then thinking about the Columbia scale, there's a lot of thoughts, and we sort of revised it a little bit. So when we first talk to someone, you kind of want to know, have you ever had a history? But then as you're working with someone, you might want to know, well, in the past 3 months, right? Or since the last time we talked. And so really thinking about what that question looks like and how that's going to change. So if I'm asking it every time, then in the last 3 months, you're probably always going to be positive. But what I really want to know is since the last time we talked, right? And so thinking about what those questions are and how you're asking. And I know when we initially did this, which seems a little bit more like common sense, we actually had people that couldn't get off high risk because of the way we had built the Columbia scale question into our system. And so that actually caused a lot of confusion. But thinking about what then for your pathway, a lot of discussions about how people get on a pathway and how people get off a pathway. So one of the things we thought as an example is there's some things we need to take into consideration to really say, hey, we're not taking kids off a pathway or adolescents off a pathway if these things are going on. So any kind of a care transition, in and out of foster care, substance abuse treatment, incarceration, a hospitalization, right? Like that's a no, you know, a no-go. You don't get a risk status change if you've had those things. If there's been a major life event, have there been any psychotic features? Also a change or a start of meds. That if there's been a change or a start in meds in that 30 days, then we're going to leave you at the risk you are. We're not going to decrease your risk. We might increase your risk, but we're not going to decrease your risk. Thinking about alcohol or substance use, right? Thinking about the time since the last, if someone had an attempt, we want to make sure that they haven't had an attempt in the last 3 months before we would change any risk status. So those are some of the considerations that we've had. I'll just stop here for a moment. People can sort of look at these. I'd be glad to have any questions or discussions about sort of, you know, what the thinking was, what we're doing, what people are doing sort of nationally, workflows, pathways. It's a lot. That was a lot.
Could you talk a little bit about how you're maintaining those pathways in terms of who's, like, what role behavioral health folks play versus medical folks versus more care management folks, and if it's more utilizing like a registry style versus some other way to be able to track those different groups?
Yeah, so the fun thing about Concert is that we do collaborative care. So we have a registry. So then we kind of already kind of have a sub-registry, for lack of a better word, right? When we think about primary care practices as an example, it's one of the reasons that I always say, you know, fortunately, we live in a world where there's a code for everything. Like, I'm sitting in South Carolina. If I walk outside, a bat falls on my head, like, there's a code, right? We got a code for everything. So there's really good codes for suicide. And so put them on your problem list. Like, make sure they're there. You can resolve them, like your active diagnosis list, right? Your problem list, so that you can resolve it and then write some information in there, like means as an example, right? But that, so it's always there. So my historical patients are there. We can see it, even though that problem might be resolved. And then it's really front and center. That helps you know your population. It also helps you put in place some guidelines, because remember, in a pathway, it doesn't necessarily matter who does it, it's that someone does it. And so that the primary care provider in a follow-up visit can say, hey, do you have a copy of your safety plan? Has anything changed? They can do the 6-question Columbia scale, right? And oftentimes do as part of a follow-up. And so it's really thinking about your setting and who, and just making sure those things happen, and really having the shared accountability for keeping people safe, you know, who are at risk for suicide. And I think that's really the important piece of it. And even if you don't have a registry, you can use your EMR to really help you do that. In Epic, you can have an episode of suicide care. You can put it on the problem list. You could have a patient type. You could open a case. Like, it really doesn't, you know, necessarily, like, there are ways to be able to do this. The important thing is to really think about, how many people do we have? What do we do differently for them? And how are we sort of stratifying them? Because we want to make sure that people are getting the right care and the right kind of follow-up. And interestingly, you mentioned, you know, sort of behavioral health providers. We're actually in the process of submitting an article now to one of the social work journals, where we reviewed our patients when we started doing this work and their risk assignment. And we found out that 75% of them were actually classified wrong in our risk stratification, because people just needed more training. They needed more comfort levels. They didn't actually know how to assess risk. And also because we hadn't put in some of the training and infrastructure that we needed to support some of the changes. So I think those are all really important pieces.
Along the same lines as Matthew was asking, my question is how much of this tracking just does your organization do through roles that are not the clinical roles? So not through necessarily through patient visits, and how do you train your roles to do this?
Yeah, I think it depends on the organization. So if you have a pathway and you're saying, you know, we're going to follow up with these patients, these high-risk patients, every 7 days, right? We're going to make sure that somebody is actually watching to make sure that that happens. And so, you know, some organizations like Centerstone has an example where if they try to reach somebody and they don't reach them, they go to their call center, right, to their outreach workers, and they get flagged as a priority. Whereas, like, you know, we might have people that work on the evenings or weekends that try to outreach people, that a supervisor gets notified if someone, you know, hasn't been in touch. So it's really thinking about the pathways and how do you reinforce, you know, to make sure things are happening, or if they're not happening, you know about them. But again, this is about using everybody on the care team, you know, to make sure that these things happen on your pathway. But there's lots happening around, you know, even the screening. So despite what the preventative task force says, if you actually talk to folks at NIMH, they'll say like primary care settings should really be screening regularly 10 and up. And, you know, for the 12 and up, putting the ASQ on the bottom of the PHQA sort of as routine practice. And that really the 9 and below, if it comes up in a visit or, you know, somebody brings it up as a concern, then you would do the ASQ as an example. But that really to be regularly screening the 10 and up. So where people are kind of struggling is, well, for my 10 and 11-year-olds where I'm not using the PHQ, what am I using? And we're actually taking this up on the AMA group the other day around some of the depression, you know, tools for some, you know, kids that age, because there's nothing sort of consistent across the board. A lot of primary care practices use the pediatric symptom checklist. And so there's thought about, well, do I put the ASQ on that? You know, maybe if it's just for my 10 to 11-year-olds. And so that was probably a longer answer than you. But
Thank you, Virna. I wonder if people have other questions. So if no one asks, I have another one. So one of the biggest
put
barriers.
questions in the chat too, like if you've got a lot of background noise or you're shy. Yeah.
So one of the biggest barriers for sites that might not have behavioral health or enough behavioral health clinicians as resources is obviously what do we do, you know, if we decide to screen universally or even if it's not universally. So I know resources are necessary as part of the answer to that, but I also know that perhaps perceptions and anxieties can be, you know, changed with some interventions at the provider level. Have you done any of those at your organization? And if so, what do you feel has helped you move the dial for this?
Yeah, so there's actually a project that's sponsored by Centene and ACU, the Association for Clinicians for the Underserved. And there's been a training now of over 3,000 primary care providers and their teams in like 30 states. And there's a couple of things we found, like 95% or better of the providers of all disciplines thought that suicide safer care was part of their role. And then we found that about half of the behavioral health providers in those settings didn't feel comfortable or competent to actually care for someone at risk for suicide. But most importantly, what we found from that project is that training really trains providers what to do for somebody at risk during the course of a routine visit. And so if you think about the workflows they have for pediatrics, right? So if I have asthma, or I bring my child in for asthma, what are some of the things that could happen? I could get a treatment. I get asked questions about my emotional triggers, physical triggers in the home. We get some education. I might get a rescue inhaler or training on teaching on how to use the space, or I would do an asthma action plan. Maybe I would get referral to a pulmonologist or for someone to come to my home, right, and do some follow-up. And so all of those things would happen. And not every asthma patient needs to go to the emergency room. And so thinking about training the providers, you have some of these workflows in place. What would happen if that kid was at risk for suicide? We get additional information, we do a safety plan, maybe we make a referral, we do the ASQ. And so if you think about the ASQ and not being positive to question 5 or the Columbia scale, we call them the yellow-orange patients, right, on that color-coded Columbia scale. What can providers do that actually they can do what needs to be done if there are no behavioral health resources, or even if there are. Not every patient at risk for suicide, they could just have a primary care visit, and we can follow up a little bit and have some workflows in place. So a lot of those trainings, we assume that there are no behavioral health resources and sort of train that way. Because if I'm a primary care patient and I come in, then you could ask me some questions, ask me if I'm safe. I don't need to see behavioral health each time. So that training is actually free. If you're in an organization and you have enough providers to sort of warrant doing a training, there's CMEs that are given, and it's actually free. You can go to clinicians.org and email them, or you can email me and I can connect you.
Thanks so much, Virna. David, you have a question. Do you want to voice it, or do you want me to read it?
Sure, I'd be happy to voice it. We haven't talked about any limitations on sharing information. And it's such a confusing area about what you can share in the realm of mental health, behavioral health. I'm just
Yeah.
wondering, it would be very unproductive if you couldn't share information about suicide risk. So
Yeah.
what's the status?
So, when we talk about doing this work, this is really part of primary care, right? So if we're an integrated care organization, this is really part of primary care. So putting suicide risk on the problem list, is actually incredibly helpful and certainly appropriate for primary care. It has primary care considerations. It's a primary care diagnosis as well as a, mental health diagnosis. And to be able to say to patients, you're really important to me, and I just want to let you know that I put suicide risk in your chart because I want to make sure that every time I talk to you, or my team talks to you, or I see you, or my team talks to you, we make sure you're safe. And so really giving providers or teams language so that people understand that it's going in the, the chart and why, but that information can be shared. And I personally think that having that conversation, so, in a prior life, I actually worked for a health center network, and we shared that information in our portal for providers and specialists that were part of our system. Because if you go to see the pulmonologist for your asthma, I want them to know and maybe ask you if you're safe. And so sharing this information is part of care. It's part of saving lives, and it's part of primary care. And the notes that people type in integrated care settings, we all have to know the difference between a progress note and a psychotherapy note, but really the progress notes, safety plans, all of that are and should be in the charts and available for everyone.
Thank you.
I got a question just to me in the chat around liability. And so, one of the things we know is that sending someone to the emergency room all the time can actually be harmful to them. And so one of the best things you can do is really follow evidence-based pathways, have a pathway that you follow, use evidence-based, tools and interventions. And that really is, like, from a liability standpoint, in addition to a, good care standpoint, that's really the best thing that you can do.
Excuse me, where would you find that information?
Which information?
On these evidence-based pathways?
On the Zero Suicide website is actually a really good place. And also there's some ones that we've done at Concert and have been done nationally there. Also, I shared probably 10 or 15 different documents, including pathways and articles that can be shared out as well, that I'm assuming you'll get. For Maria, I sent them to her over the weekend in multiple emails. So that actually can all be shared, and I'm glad to share all of that information.
Great, thanks.
This is really hard work, and I think it's, as you think about training, but really identifying kids who are at risk for suicide and training and putting pathways in place is going to be some really important work that we all take on.
Well, thank you so much, Verna. And I think we can keep the discussion going. I did want to kind of turn it over for a few minutes to Rachel to review an article related to the ASQ for our research corner part. I thought it was really helpful how you kind of distinguished though, Verna, like the kind of this care pathway versus having to delineate, a pathway where, an exact person is doing a particular aspect of it. And that way, if you can build these kind of evidence-based pathways, then each organization can kind of find a way of making it their own. But I thought that was really a helpful way to.
And versus policies, like one of the things we don't recommend to organizations is you have a suicide care policy. Like, I don't know if any of you, I'm sure you have had the pleasure of like a Joint Commission visit or CARF or, HRSA or something equally as painful, like looking through the policies, like that's something you can get dinged on, but actually it's kind of a liability, like, in terms of any adverse event, whereas to have a pathway is actually much better from a training, implementation, operations, liability, sort of, and keeping that pathway front and center, and then building your system to help reinforce that pathway, building your training to reinforce that pathway, so that's really, you're making sure those things happen.
And I will also just share, this was really interesting. Thanks for providing this information. In our clinic, we've done a very scaled down version of what you shared. And one of the things that I found that helped with physician buy-in is acknowledging the fact that we really don't know a lot about suicide risk. And while these are really great places to start, identifying kids who are at risk are really challenging, especially when kids are impulsive. And so I think one of the things I really noticed is when physicians are used to things being yes or no, or in this range or not, and it's unfortunately just not that clear to assess risk in suicide. And I think it's really important to just acknowledge that.
And risk could change, right? Like, especially like I could not be at risk. Like I've discharged people from emergency rooms who tried to die by suicide that morning, right? They weren't at risk, and people would be like, what? And so I think one of the things that I find helpful is to talk to providers. Like I love the Now Matters Now website because I love sort of those DBT skills that it gives and that safety plan, and being able to say to providers like risk can change. And so when we were all young, we learned what to do if we caught on physical fire, right? We would all stop, drop, and roll. Like, I don't know when I learned it, but man, I know it, right? And so even though the likelihood that I'm going to catch on physical fire is pretty low, well, I want you to know what to do if you catch on emotional fire. Even though the likelihood that you're going to catch on emotional fire is low, you're going to be prepared for both. And so here are these things. It turns out some of the same things work. If I stop, drop, and roll, I'm not dying by suicide, right? If I splash cold water, I'm breaking some of those repetitive thoughts. And so that emergency, it's not really, I guess it's called an emergency safety plan, but sharing some of those basic skills with that language often can be helpful for providers, because they have something concrete that they can give to people and feel like they've given them a tool should that risk change. But yeah, it's scary. I mean, especially in some of the special populations, the LGBTQ or some, it's hard. It's really hard. Yeah, there's a great section on the Now Matters Now website for providers too, with some DBT skills if you've never been to the website.
Well, I know we were talking about the ASQ kind of before, and that being part of a pathway maybe. And so, Rachel, do you want to explain a little bit more about that particular tool and what the article that you reviewed was showing?
Sure, yeah. Let me share my screen here. Actually going to be sharing a study that our own Cody was an author on. So feel free to jump in, Cody, at any time as I go over this study. And something that I like that Verna kind of shared in her presentation is kind of the question of, what research supports the decision you make in terms of screening and your pathways. And so here's kind of an example, I guess, in terms of research supporting the use of the ASQ in addition to PHQ-9. So we can kind of talk through that and see if that also kind of built off of, some more discussion. But as we've been discussing in here, we discussed last month, we know the task force said there was insufficient evidence to universally screen for suicide risk, yet many of us discussed the need to continue to do so. And I think Verna gave a nice kind of demonstration of how to assess for suicide risk given different kind of factors and age and things like that, risk factors. We do know that depression screening in general is recommended. That could help us identify those at risk for suicide. But obviously a little bit more targeted assessment is likely needed. So the purpose of this study was really looking at the incremental kind of yield of adding suicide screening to depression screening in order to detect suicide risk in adolescents. So in the study, there was 972 teens 12 and up screened with the PHQ-9A. So here on the side, I have screenshot of the PHQ-9A questions, and also within the study, the percent positive that was endorsed by the sample. So they were given the PHQ-9A and the ASQ. This was across 12 primary care clinics at nationwide between June 2019 and October 2020. You'll notice if you're familiar with the PHQ-9, it's a little 9A, it's a little bit different than the regular PHQ-9. There's 9 questions and then some. There's a few extra here at the bottom that gets at suicide or asks some suicide related questions. And the ASQ, if you're not familiar, here's some of the questions related to that are asked with the ASQ, and then the kind of percent positive in the sample in this study. So in terms of overall positive screens, they kind of divided it into different categories. So there is a positive screen for any type of depression. So we know the PHQ-9 does screen for MDD, and there's kind of scoring capacities for that, but some teens are going to kind of endorse symptoms and maybe might present in kind of mild depressive symptoms or adjustment or something else. So any kind of positive screen for depression defined in this study as a response of 2 or 3 for questions 1 through 8 for the PHQ-9, or 1, 2, or 3 at question 9. And 2 or 3 is more of just endorsing more, this is occurring nearly every day or most of the time every day. So over half of the teens screened positive for any type of depression. And when they add it up in terms of kind of the screen for MDD, you have a total score of greater than equal to 10. You had about a quarter of the teens screening positive. And as it pertains to the ASQ, they defined a positive screen result for suicide, which is answering any of those ASQ questions, as you saw previously, endorsing any of them in the affirmative. So you had 20% had a positive screen for suicide. They also looked at characteristics associated with the kind of positive screenings, which is interesting. So the proportion of positive screens for any kind of depression actually decreased with age. So the older they got, there was less positive screens. Perhaps no surprise that girls more likely than boys to have positive screens for any depression, MDD, and suicide risk. Non-Hispanic Black patients had a lower proportion of positive screen results for suicide. And in the sample, it's interesting, Cody could probably speak to this, there's kind of a Somalian population within Columbus. And so patients who preferred to speak Somali in the home had a lower proportion of positive screens for any depression, MDD, and suicide risk. So this gets at the incremental kind of, I guess, positive incremental proportion of positive ASQ score. So basically, it's kind of almost kind of comparing when you add in the ASQ, who else do you kind of add in? How much more positivity screens for suicide do you get? So if you kind of compare it, if you with the past month suicidal question with the PHQ-9, you add on the ASQ, you get about, I think it was 11% more in terms of people screening positive. And so you can kind of see that there's different ways of screening. So PHQ-9 screen for MDD, so just using all of the PHQ-9, you add in the ASQ, you get an extra 8% screening positive. So the kind of incremental, it seems to be, at least of adding in the ASQ, kind of increases your positive screening regardless of the type of PHQ-9 screening you may be using. This is kind of getting at those additional yields, the percentages that were in that figure. So ASQ identified additional cases of suicide risk above and beyond the PHQ-9. So we can feel good about using this. And I think, as Verna kind of discussed, adding it on to the PHQ or adding it on to some other measure that you're using. So we have some evidence to support that this captures more. And I think in general, kind of the positive screening really underscores the importance of some of the universal screening that many of us are doing, and the prevention and intervention strategies. And that is the reference. So I'll stop there and open it up. Cody, feel free to jump in.
Rachel, I want to ask you a little different look at this data. Cleveland Clinic published a study where they used the Columbia anytime somebody answered the 9th question non-zero in the PHQ-9, and they reduced the number of false positives for suicide by 75%. You know, indicating that the PHQ-9 is a very rough measure of suicidality. It's too easy to say something that triggers a whole suicide protocol. So they immediately would administer the Columbia, and it ruled out a lot of people who were not suicide, who, you know, answered the 9th question positive for some reason. So I'm just wondering if you saw any of that in your data. I do appreciate picking up more suicide cases by using SQ, but did it actually ever show indications that it would rule out suicide? You know, what happens if you get a completely negative ASQ?
I'm gonna let Cody jump in on that, because I'm not sure, based upon the manuscripts. A great question.
Yeah, we didn't write that part up for sure. I appreciate that question. I appreciate you too, Rachel, highlighting some of the research that we're doing here. So that is actually our workflow. So once you've screened positive on either the PHQ or the ASQ, we do the Columbia, as well as dynamic and stable risk factors, and come up to a risk level and safety plan. So that is a kind of our workflow. And all of our sites either have a medical social work or integrated behavioral health provider. So that's kind of our workflow, is that it's an automatic handoff for us when either of those are elevated, so we can do the Columbia.
So can I just ask you a question? Did I hear you right, that if if I'm positive on the PHQ-9A, which I think we used to, I mean, the data's out there that yes, you're more likely to die by suicide, although there's more and more literature out there now that says you should just ask the suicide questions, right? But did I hear you say we do the ASQ and then the Columbia scale, like somebody would theoretically get both?
Yeah, so we do the full Columbia afterwards to get a risk level, and then to kind of make a determination after that. So we really look at the ASQ and the PHQ-9 as a screener, the Columbia as the assessment, the risk assessment.
Yeah.
That helps us engage our decision making following.
Yeah, it's interesting because there's been a lot of animated discussions around like the longer version of the Columbia scale, and I definitely think it has use. I think we originally had discussions because what do I really need to know is where you are, like, are you high risk? So do you have intent, right? And putting you at high risk and then saying, we're going to do this level of follow-up, training people to do some DBT interventions. Like, would I do something different if I did the long Columbia scale, right? Like, and so there's been a lot of discussions around that. And I know that, at Concert, we sort of opted out. I also think a lot of people don't know how to do it well, and we lose patients. And like, when you weigh the benefit, the pros and cons of that, like as an organization. So I think there's a lot of considerations, but okay, thank you. That makes more sense to me what your workflow is.
So Cody, I have another question for you. I noticed that your catchment period bridged the COVID shutdown. And so do you have different statistics for the first half of the period versus the second half of the period when we know the prevalence doubled or tripled?
We didn't find a difference. And I think a big part of that is we treat a pretty vulnerable population as part of it, or a population that tends to screen pretty high to begin with. So if you saw some of those screening rates, I mean, they were extremely high, jumping anywhere between 11 to 20% of kids already screening positive. And so within this specific data set, we did not notice any jumps. It's actually, though, we have ongoing work with this, right? So we have quality improvement task force and things who are constantly monitoring this data from a population health perspective, and we have registries. And we have found actually that it was much later in the pandemic where we started seeing some increase in acuity and some positive responses. But even the positive responses didn't really jump up as much as we expected, but it was more the acuity, and kind of in the later part of the pandemic is where we started to see some increases.
What do you do differently with the levels of acuity? So if I'm at level X versus level Y, like what happens different on the ground?
Yeah, a little bit to my chagrin, for a long time, nothing. And as a clinician, it was a little exhausting given how many of these things we do every day. We are just now finally, and I think our goal was like, let's do all we can for everybody first. And when we start to get comfortable following the full Columbia and the full procedures, once we feel like we're really good, then we can start backing off and start kind of tailoring things a little bit. And that's what we're in the process of now, of identifying, like a historical only 4 years ago in the middle of a really hard, difficult, acute moment that's been resolved and nothing since, probably should be treated differently than something that happened a month ago, and the situation is still ongoing. And so we're kind of working through that a little bit now to kind of revise them. We're a big system, and we wanted to make sure that we were kind of doing everything to the T, at least at first.
I mean, and I think, the biggest one of the, I mean, I made a ton of mistakes in my career, but one of the mistakes, probably 4 today, but like one of the bigger mistakes that I made doing some of the, like, I actually fell into the zero suicide work because I was like doing the work, and because I was seeing more suicides in my system. And one of the mistakes I made was like, I threw lots of things at it, lots of ideas, but never really put systems in place to track like what was really working and what didn't. And so, now I've learned to try to be more thoughtful about that so that you can really make the system changes based on the learning. But as you go forward, I applaud the work that you're doing. We've just partnered with some friends in Montana. I know Liz is on the call to do some research, and have been doing quite a bit in the suicide space. So if you ever want to have a conversation and see if there's some opportunities to do some learning together, and that goes to anyone on the call, then I'd be glad to do that. There's a question in the chat about the billing. So if somebody screens positive for suicide risk and the visit shifts to safety planning, does the time get added to the PCP's E&M code? So it depends on who's doing it or both, right? It could get the time and complexity of that provider. E&M could go up from a 213 or 214 or whatever it happens to be, or even an add-on code, depending on the setting or whatever. And then if the behavioral health provider would see them, the crisis code, that 9085939, is only going to be if it meets the criteria for that, like the hour, right? But it could be a psychotherapy code, and then your safety planning is a clinical intervention. So you could bill a psychotherapy code for that, unless, you know, you couldn't do same day billing. So there's a lot of variables there, but that would probably be where it would go.
Yeah. Yeah, for those of you who've heard me talk about a program before, we have like a really highly integrated model. So as a psychologist, 80% of my patient contacts are actually on the physician's schedule, and we have some really nice payment structures and just organizational initiatives that allow us to be able to do that. So we're kind of a routine part of care for many patients anyway. So this just becomes what we do for them on that day. And we do usually bill therapy codes in these situations. Yeah, for pediatrics.
Mm-hmm.
So let me get this straight. If you're in a state like California, where I am, where you can't have same day billing for 2 visits, does that mean you can't get paid to do a suicide plan?
Well, again, it depends on who's doing it, right? So if the behavioral health provider does it, and California is the most complicated state,
Yeah.
but does it as part of the provider visit, you could add to the time and complexity of your E&M code. You guys have the collaborative care codes now, so you could do something there. Like, it really depends on your setting and who's doing it. That's the problem. Like, there's a billing sheet on the Zero Suicide website that's semi-helpful, but it doesn't break it down by state.
Yeah, it gets super tricky, and like whether the behavioral health provider is employed by the same group or they're kind of partnered with. So if you have the same tax ID billing for the same code versus sometimes in our community where we will partner a community behavioral health organization with a primary care organization. So they actually have 2 separate billing IDs, and so they can actually bill the same day. So it gets extremely complicated depending on kind of your local state laws and how you design the model.
And that's just your Medicaid patients, whereas your commercial and your Medicare, you could actually, you know, with different diagnoses or whatever the case may be, you know, potentially bill. So
then there's the whole incident 2 stuff. It gets really, yeah.
Like, I'm going to share in the chat, the National Council just put out a billing tool, and it goes state by state, and it's like integrated care. If you haven't seen it or heard about it, oh, it didn't cut and paste for me. Okay. Then it actually could be helpful for some of these, you know, might be helpful. I'll put the link in the chat if you haven't seen it.
Thank you so much, Virna. I know we are at the top of the hour. I would love to continue this conversation, but unfortunately we have to stop here. I hope you can all join us next month, and happy holidays, whatever you celebrate.
Thanks, everybody.
Thank you. Have a great day.
Happy holidays.
Hi, everyone. Thank you.